Good afternoon, everyone. Good afternoon, and welcome to our afternoon address. I'm Dean Reuter, Vice President, General Counsel, and Director of Practice Groups at the Federalist Society. I'm very pleased to introduce our guest today. I will break from the authorized introduction to say that he came to us from the White House this afternoon, where he was going to attend an awards ceremony that was running long. So rather than spend time at the White House, he came to be with you. So special thanks to Alex Azar. Alex Azar was sworn in as President Trump's Secretary of Health and Human Services in January 2018. His current tenure at HHS is a second tour of duty for him at the department after serving as General Counsel and then Deputy Secretary in the 2000s. He spent his entire career working in senior healthcare leadership roles in both the public and private sectors. And it's very much a pleasure to introduce to you the 24th U.S. Secretary of Health and Human Services, Alex Azar.
Well, Dean, thank you very much, and good afternoon, everybody. Thanks so much for welcoming here today. It feels a little bit strange to be giving an actual speech to this crowd, given that I know so many familiar faces here. A little awkward to be just speaking instead of having a discussion, but I've got so many fond memories of my work with the Federalist Society over the last almost 30 years at this point. My involvement began as a student at that well-known cozy home for conservatives known as Yale Law School. For me as a law student, the Federalist Society was not just an opportunity to connect with like-minded intellectual students, it was also just a way to make sure that I had somebody who would eat lunch with me. The Federalist Society serves as a support group for those who care about our founding principles and care about applying them in the courts and throughout our government. As you may know, I'm a devoted protege of Justice Scalia. That was the ceremony that I was to be at, but that ended up starting a little late, was the wonderful awarding of the Presidential Medal of Freedom to my mentor and Justice Antonin Scalia. I know that, like myself, everyone in this room misses him greatly. One of the signal lessons that Justice Scalia taught the legal world was that it can take a certain level of stubbornness to stay faithful to our Constitution and our laws. Some of his most notable opinions, in fact, on topics such as freedom of speech and the Fourth Amendment produced policy outcomes that he did not like, but he adhered to what the Constitution and the laws said. It's the easy choice to assume the law says what you want it to say. It's much harder to engage in the work of debating what it really says and means. The Federalist Society has done invaluable work by building the intellectual and organizational foundation for this kind of textualist thinking to occur, for leaders like Justice Scalia to emerge, like all the other leaders in this room. Now today I have sort of left the law behind, largely. I've got a very fine general counsel in Bob Charo, who is here, to sift through the trickier legal questions that we face. I now get to be the client. And the client that I am, the department that I run, the U.S. Department of Health and Human Services, is largely known as a creation of the New Deal and the Great Society. Certainly its scale would be mind-boggling to our founders. The department employs 80,000 people with a $1.3 trillion budget and more than 300 programs. We are twice the size of the Defense Department. We are 1/4 of the U.S. government. Standing alone, we would be the 6th largest government on Earth. That's right, the U.S., China, Japan, Germany, much to my chagrin, France, and then HHS. Don't worry, we'll grow our budget. We're going to beat France, don't worry. But just because we have got a massive, complicated system doesn't mean there can't be simple principles for reforming it. One of our great presidents, whom everybody in this room has such great affection for, President Ronald Reagan, applied common-sense solutions to the supposedly intractable challenges of his time, like an overly complicated tax code and a bloated, broken welfare system. He had a pithy description of how problems are usually handled here in Washington. Government's view of the economy could be summed up in a few short phrases, he said. If it moves, tax it. If it keeps moving, regulate it. And if it stops moving, subsidize it. Now, for too long, that has been more or less the federal government's approach to health care. We saw it most recently with the Affordable Care Act, which imposed a new tax or regulation, or sometimes both, on just about every moving part in our healthcare system. There was even a tax on not buying the right kind of insurance until President Trump and Congress repealed it. Last year, 6 million Americans paid over $3 billion in taxes for the privilege of not buying health insurance that they did not want and could not afford. The Trump administration's first instincts are the opposite of the big government nightmare that President Reagan described. If something in our healthcare system isn't working, we'll see if there's a regulation in the way. If prices are high, we'll see if there's a tax involved. If prices keep rising, we'll see if there's a subsidy driving them. This thinking has been ingrained in me for a long time. In fact, one of the other maxims that I keep in mind came from one of my favorite professors I had at Yale, Professor Robert Ellickson. I found it useful to choose law school classes more by the professors who were most engaging than by the actual subject matter, which is how I ended up in Bob Ellickson's land use controls class. Yes, I took land use controls in law school. The great lesson that he had for us was this. He would say, when you take Metro North from Connecticut into Manhattan and you see land with burnt out buildings or land that's not being put to its highest and best use, even if just as a parking lot, ask yourself the following question. How is the government involved here? And while it's sort of amusing, that really is a guiding principle for me in thinking about economics and regulation. When things don't work the way they should, when we ask why the rest of our economy is fully digitized while healthcare isn't, when we wonder why healthcare lacks the dynamism and consumerism of the rest of the economy, I look for culprits. And so very often the culprit is government action, sometimes from decades or even a century ago. In some cases, government action may be needed to fix what government action broke. Sometimes the necessary government action may be strong medicine because markets have become so distorted or so diminished, and special interests have become so vested in the status quo. And sometimes our solutions, because of political realities, may be subject to the law of the second best, to use law and economics speak. Always, however, our actions will be aimed at building markets and competition, restoring price signals and incentives, and empowering consumers rather than having government decide what is best for the individual. Now, this can be a bit of a contrarian approach to healthcare, just as the Federalist Society's approach is to the legal world. No other country on the planet has a written constitution, federalist system, and respect for individual rights in the way that we do. And no country has a free market healthcare system respectful of patient choice and open to innovation like the one that we have. That doesn't mean our health system is perfect or even fully competitive. Far from it. Just as with our constitutional system, maintaining the freedom we have in healthcare requires constant vigilance about the unintended consequences of programs and rules that we have, and an openness to reforming them. This is true for each of the 4 priorities that I've laid down for HHS. Reforming the individual market for insurance that Obamacare undermined, bringing down the high price of prescription drugs, fighting the opioid crisis, and moving to a healthcare system that pays for health and outcomes rather than procedures and sickness. With each of these challenges, part of the problem we face is the unintended consequence of sweeping centralized government action. Obamacare usurped the power states traditionally had to run their own insurance markets, imposing new regulations and new open-ended entitlements rather than doing the hard work of building a fiscally sustainable, state-run, consumer-driven system. In prescription drug pricing, government action has helped create a broken system that works for all of the special interests involved, but not the patient. We've got a system where everyone makes their money as a share of a drug's list price. This means literally the higher price you charge, the more appealing your drug is within the channel and the market. Meanwhile, many patients pay their drug costs as a share of these ever-increasing prices. The opioid crisis had at its root, in part, a hubristic idea about how we can treat pain, which was reinforced by short-sighted government payment policies. We seized on quick pharmacological fixes and produced deadly unintended consequences. Finally, for the last half-century, government regulation has dominated the way we pay for healthcare services. So it's little wonder that we keep paying more and more for them. Regulation is one of the most significant sources of unintended consequences, an issue this administration takes very seriously. It's an issue that some people in this room, I know, actually enjoy talking about. When we talk about the administrative state, we typically think of rules from the FCC, the NLRB, and all of the early 20th century progressives' alphabet soup of agencies. HHS is attentive to the costs that we impose on market actors with these kinds of rules. In the last year, by OMB's accounting, we cut more economically significant and burdensome regulations than any other cabinet department. That represents $12.5 billion in savings in present value terms, earning us not just the #1 spot, but actually making up half of the entire U.S. government's regulatory savings. President Trump set a goal of removing 2 regulations for every 1 new regulation imposed. At HHS in 2018, we took 5 deregulatory actions for every new regulation imposed. For physicians alone, we estimate that our reforms will save 53 million hours of paperwork every year. But perhaps the most significant federal rules that go through notice and comment every year aren't quite traditional regulations. They're payment rules issued by our Centers for Medicare and Medicaid Services. Each year, physicians, hospitals, and other healthcare facilities are told by the federal government, I'm afraid to say by me, how much they're going to get paid by Medicare and what they need to do to get paid. Now, they don't have to take Medicare. A slice of doctors, often very high-quality doctors, do not. But the size of Medicare is such that for many it is a mandatory system, and a system that effectively micromanages so many of their decisions. We tell them exactly what we'll pay for and how they need to fill out a form to get paid for it. Imagine the standard legal process of billable hours. I know, PTSD for all of you. I don't have that anymore. Except imagine the federal government running that process. And the time you spend to comply takes time not away from a legal client, but from a patient who needs your attention and care. In other words, nowhere does the administrative state loom larger than in the place you'd want it least, your doctor's office. So what if instead of sticking with this status quo, we radically simplified these burdens? What if we said, we'll pay you a certain amount for each patient you take care of if you keep them healthy, if you produce good outcomes, you can keep the savings. It's sort of like being on retainer rather than billing for every hour. Of course, some patients are riskier than others, just like some legal clients are riskier than others. Thankfully, in healthcare, we actually have quite a good system for risk adjustment, which I'm not sure exists for picking out clients. Most importantly, the more risk that healthcare providers are willing to take on, the less we will micromanage the work that they do. Let me give you a plain English example of how this would work. I have a relative who was recently in a rehabilitation hospital. When I was there, it's hard to be a patient as a health secretary. It's also very hard to be a caregiver as a health secretary, when that's known. The nurses kept coming to me saying, you've really got to do something about the staffing ratios that Medicare mandates, the ratio of doctors and nurses on the floor at the hospital. So I called our CMS administrator and I said, do we have anything to do with regulating the ratio of doctors and nurses on the floor of a rehab hospital? She said, well, yes, of course we do. We tell them exactly what has to be done. And we came back together here in Washington and we said, there's a different vision. The vision should be, if my relative walks when he leaves the hospital should get this amount of money. And if my relative is in a wheelchair when he leaves that hospital, they ought to get less money. And other than doing things ethically, we really ought not care how they get from here to there. So the more risk providers are willing to take as a burden, and the more they're willing to share, then the less we should be micromanaging how they practice medicine. And this is how we're going to accomplish what those of you who work in healthcare or follow healthcare policy know as the shift from volume to value, where insurers pay, where the current system of volume, where insurers and the government pay for procedures and sickness rather than paying for health and outcomes. There's a well-known economic axiom, one I think even lawyers understand, that when you pay for something, you get more of it. When we pay for healthcare procedures, guess what happens? We get more of them. The federal government simply can't afford such a system. Margaret Thatcher had a famous quip that the problem with socialism is eventually run out of other people's money. The problem with Medicare today is that we already are running out of other people's money, and those other people happen to be our children and our children's children. The Medicare Hospital Insurance Trust Fund will be out of money just 8 years from now, necessitating large tax increases or benefit cuts. If you think the federal government spends a lot on health care now, consider that over the next 30 years, the share of our economy spent on Medicare and Medicaid is projected to double. Reforming the system in the way that I've described towards value will go a long way toward putting us on a sounder fiscal footing. But as I've laid it out, it's worth remembering how it will also be a huge rollback on the role that government plays in American life. I want to now discuss another area of healthcare where government rules are firmly entangled in how we propose to reform it: prescription drug pricing. Earlier this year, the President laid out a vision for bringing down the prices Americans pay for prescription drugs using 4 strategies: more competition, better negotiation, incentives for lower list prices, and lower out-of-pocket costs. Each of these, first and foremost, is going to rely on market forces. This includes areas of competition you are probably familiar with, like rapid approval of generic alternatives to expensive branded drugs. The Food and Drug Administration has approved a record number of generic drugs the last 2 years under President Trump. Generic approvals from January 2017 through July of 2018 saved American patients $26 billion in drug spending. According to new numbers from the FDA, we are actually paying substantially less for generic drugs than some other wealthy countries do. But we could still use more competition and market forces. Today, we prevent Medicare Part D drug plans. These are the drug plans that cover spending when the senior walks into a pharmacy for a drug they'll take themselves. And private Medicare Advantage plans. These are the private plans that run for 1/3 of our beneficiaries their Medicare benefit package, from using all of the tools that private commercial insurance plans already use to negotiate lower drug prices. We've already taken steps to allow these programs to use these same tools, and we're going to continue this effort. In bringing down drug prices more broadly, we're going to rely on market forces, including providing transparency around prices and empowering patients as consumers. But there are also places where right now Medicare pays for drugs with a price-setting system, and there's no practical alternative that I've been able to yet find. For some of the most expensive drugs that Medicare covers, these are the infusion drugs that a physician administers in their office. It's a separate payment system with a single-payer government system. We currently pay a set price, and yet we set that price at a sky-high level, list price plus 6% effectively. That's almost double what other wealthy countries pay for the exact same drugs. So President Trump has put forth a model that will reset the prices we pay for many of these drugs, bringing it much closer to what other wealthy countries pay. This is actually a market-based price. It's not determined by some expert's idea about what the drugs are worth, but rather using in part the discounts that manufacturers themselves voluntarily agree to sell their drugs to other countries for. While such a price-setting system is still not ideal, we can at least make sure that we're paying a fair price and no longer subsidizing other countries with our investment in research and development. The reforms I've described today in healthcare payments and prescription drug pricing are going to deliver better outcomes for American patients by unleashing market forces and curtailing the footprint of government. This is not, to put it mildly, the traditional vision for health reform, nor is it one that large incumbent market actors are always going to be happy with. But luckily, we've got a president who is willing on health care and much else to do as Justice Scalia often coached me, to stand against the wind. I don't think this is because he's surrounded himself with so many FedSoc members, so I'm sure that doesn't hurt. The president's willing to deliver change because he understands the need for fundamental reforms to the programs our federal government runs. He knows our system isn't delivering the results for the forgotten men and women of America, and he's willing to fix it. It's actually an irony of history that we who call ourselves conservatives are willing to shake up a system that is not working, while those who call themselves progressives often stand in defense of the status quo. Systemic reform means asking hard questions, just as textualists ask not what we want the law to say, but what it really says. We have to ask ourselves not what our government programs are trying to do, but what they are really accomplishing. Asking these questions and executing on what we learn, is the way to reform the important programs that we run, bring real competition and freedom back to healthcare, and deliver the good government that Americans deserve. Thank you very much. It's a pleasure to be with you today.
Well, thank you, Secretary Azar. There's another saying about Congress that I like to recite, and that's one that Congress spends money like a drunken sailor. But of course, that's unfair to sailors because they stop spending when they run out of money. But thank you so much for being here. I mentioned at the outset that Secretary Azar skipped out on a White House event to be here, but let's just make that our little secret in this room. So with that, Secretary Azar, thank you so much for being with us. If you could remain in your seats while the Secretary leaves, thank you so much.